Ladies and gentlemen, distinguished guests, professors, colleagues, and friends, welcome to the Endowed Professorship Public Lecture Series. My name is Paul. I'm a resident at the Orthopaedics and Traumatology Department at the University of Hong Kong and Queen Mary Hospital, and it is my pleasure to be the MC for this evening. The Endowed Professorship Lecture Series first started in 2014, and this is the fourth lecture in its series. And in fact, this is actually the first lecture for the endowed professors of the Li Ka-shing Faculty of Medicine. The Faculty of Medicine is the oldest institute for higher education in Hong Kong. It was first founded in 1887 as the Hong Kong College of Medicine for Chinese, and later renamed to the Hong Kong College of Medicine in 1907. It was a premier founding faculty of the university when it was established in 1911. And since then, the faculty has expanded to become the largest in the university, comprising of 14 departments: the School of Public Health, the School of Nursing, the School of Chinese Medicine, as well as the School of Biomedical Sciences, as well as a number of strategic research centers with excellence. And therefore, without further ado, I would like to now invite Professor Leung Soo Yi, who is the Associate Dean of the faculty, to come and give a welcoming speech. Thank you very much.
Mr. George Joseph Ho, Professor Peter Matheson, Professor Paul Tam, Professor Andy Hall, distinguished guests, ladies and gentlemen, good evening. It gives me great pleasure to welcome you to the Endowed Professorship Public Lecture by Professor Kenneth Cheung. Since its first inauguration in 2005, the scheme has established a total of 84 endowed professorships, among which 48 chairs has been created at the Faculty of Medicine in areas such as spine surgery, pathology, infectious diseases, community trial health, molecular medicine, and public health. Each endowed professorship constitutes a partnership between the University of Hong Kong and a great donor, with a noble mission to benefit the society through excellent teaching and world-class research. Today, we have an excellent example of this everlasting partnership. Our generous donor, the late Mr. George Ho, had been a staunch supporter of the University of Hong Kong. Apart from the establishment of various scholarships, he established the Jessie Ho Professorship in Neuroscience and the Jessie Ho Professorship in Spine Surgery in loving memory of his wife in 2008 and 2012, respectively. The late Mr. Ho's belief and contribution to the research and development of medical sciences will live on and continue to benefit patients, especially who relied on researchers and surgeons' expertise to recover from spinal complications. Professor Kenneth Cheung, incumbent professor of the Jessie Ho Professorship in Spine Surgery, will be speaking on a topic entitled "A Pain in the Backside: Understanding Back Pain Problems from the Young to the Elderly." Professor Cheung is a clinical professor and the head of the Department of Orthopaedics and Traumatology of the University of Hong Kong. He is one of the surgeons leading the field in search of novel ways to prevent, repair, and manage complex spinal disorders. Professor Cheung has over 200 publications in international peer-reviewed journals and 12 book chapters. He holds 13 patents and has 16 personal awards for research excellence, as well as 37 additional awards by his research team members. Notable, in 2008, he became the first clinician scientist residing in Asia to have received the Henry Farfan Award from the North American Spine Society for his outstanding contribution in spine-related basic science research. In 2010, he received the prestigious ISSLS Prize from the International Society for the Study of the Lumbar Spine, awarded annually to the most significant contribution in clinical spine research. Professor Cheung has secured multiple research grants from local, regional, and international granting bodies, totaling over $5 million. He is the current president-elect of the Scoliosis Research Society, and he will become the first non-North American to become president of this prestigious learned society in her history. Professor Cheung is going to discuss with us the various causes of back problems and practical ways to tackle the problems, innovative treatment options, and related myths. I believe today's lecture will provide us with valuable insights into the forefront of spine research and clinical treatment. Lastly, I would like to thank all the staff and students who have been working so hard to organize the event. I'm sure that you will enjoy the fruit of your labor and benefit greatly from Professor Cheung's insightful lecture. May I now invite Professor Cheung to the stage to deliver the lecture. Professor Cheung, please.
Thank you. So I thank you very much for your very kind introduction. Distinguished guests, there are so many of you here, it's difficult for me to name you one by one, so please forgive me for not doing so. But I would like to especially acknowledge Mr. George Ho for coming along to this lecture. Now, because Mr. George Ho Sr. is, of course, responsible for the endowment of my professorship, and this is a picture that was taken at the ceremony in 2012. I have enjoyed very much interacting with him. His love of life and some of his very funny anecdotes that we often talk about is really quite inspirational. I also like to, at the beginning, just acknowledge members of my department too. And I know many of them are here tonight. It is because I work with such a talented group of people that I'm able to do what I do in the department. So I thank them for their support. Now, it's not easy to give a public lecture like this because we have the most senior professors in the university, and we have students from different faculties here, and we have laypersons from the community in Hong Kong. So where do I pitch it? So I thought the best is if I have some real cash. And I'm going to put it on the stage here. Now, there are various reasons why I might want to do this. The first is, of course, in fact, I thought perhaps I should give one of these to every person that comes along to the lecture. Thank you. But then that would not be very good because I'm sure that you come here not because, I don't want you to come here because of the money, but because you want to listen to me. So I thought then perhaps because it's such a wide audience, some of you will no doubt fall asleep during parts of the talk. So I thought perhaps I should give it to the person that stays awake throughout the talk. So I'll be keeping an eye on all of you. But perhaps more seriously, for those who suffer from back pain, and I think I've already met a few of you outside who suffer from back pain, you would realize that if you see money on the ground like this, you would not go and pick it up. Right? So this is the plight of people with back pain. They have very few sympathy from those who do not suffer from back problems, but for those who do, you would realize that this is very real, right? So I'm going to leave it there, and we'll see what happens at the end. Now, as I mentioned, back problem is a significant problem. This is a publication in The Lancet in 2013 looking at the global burden of disease. And you can see that for non-fatal health problems, of course, non-fatal health problem, back pain is ranked #1 in the world. So it's a significant problem. Quick poll, who has back pain or who has or have had back pain here in the audience? Thank you, yes. You do not get any money at the end, okay? No money for you, okay? The other people can line up at the end. Now, so it is common. And that's why you see that the annual prevalence is 15 to 45. In fact, it is often said that perhaps 80% of the people in the world will sometime during their life have an episode of back problem. Okay, so it causes activity limitation in young people, and that's why there are young people here, perhaps. Third most common reason for surgical procedures, loss of work days, as well as a significant societal cost because of this loss of work days. So this is something that we in orthopedics and I have been interested in for some time. The trouble with back pain is that it's a subjective sensation. You feel it, but nobody actually knows that you have got it. Now, I'm fortunate that I don't have it, but I see a lot of people who does. And it's also difficult to quantify in the sense that, some people, pain is a very subjective sensation. You can hit somebody with a hammer and nothing happens to them. But you touch another person, they jump off the ceiling. So this is very subjective and I think therefore difficult to measure. Very difficult for us to understand and to quantify. And in that respect too, it is often, for those who are employers here, is also open to abuse, right? People say, I'm calling sick leave, I've got back pain, and you have no idea whether they really have back pain or not. You can't tell. You just have to take their word for it. Importantly, there are many different causes, and we'll talk about some of them in a minute. But as I mentioned, it can be very painful, and yet you walk over to the $1,000, you look at it, and you walk past. People think you're just crazy. You don't even go and pick up that money because of the pain. Okay, so for those layperson, we'll start at the beginning with the spine. So this is your spine. I often kind of refer to this as the kind of major building column of your body, if you like. So everything hangs off the spine. That's how important it is. Okay, and then of course the spine has vertebral bodies, which are bone, and in between those are the discs, the intervertebral discs. And each disc is a joint, so when you bend over, they have to move. Now, we can visualize this in any person by taking an X-ray, and this is an X-ray of the spine showing bone. And then because X-ray, you can only see bone, the discs are hollow. They look kind of translucent. We can see the soft tissue or the disc by taking an MRI scan, and I'm sure many of you are familiar with this also, in the sense that now the discs become visible as these areas here, little segments, rather like a kind of piece of bamboo. And also you can see at the back the spinal canal, and inside the spinal canal are the nerves. And sometimes they can be compressed. Now, when the spine gets into trouble, for instance, if it degenerates, then you can see that there are changes on the MRI scan, which sometimes we look for. For instance, here, the disc is narrowed, while this one is relatively white and normal, so this is narrow and black, okay, just narrow and black. And sometimes it can also, the inside of the disc can actually also herniate or kind of move, migrate into the spinal canal, and you can see that it can impinge on roots, and that can give you leg pain and so on. There are many different reasons for back pain, and that's how I just want to show you this schematic picture, because you will see that here's the bone again, and here's the disc, and here's the canal inside are the nerve coming out like this. So there are different joints, ligaments, nerve, disc, bone, all can be painful. So part of our job is not just, you have back pain, so you must have this, right? You have to actually diagnose where the pain is coming from. So common causes of back pain. Well, for the majority of the people, fortunately, they actually just have a kind of what I call a kind of back strain. In other words, it's rather like a sprain in your ankle, if you like. So you pick up something heavy, it hurts. Okay, fortunately, for the majority of people, this kind of back strain is a self-limiting condition. You may rest a little bit, take some painkillers, perhaps have a little bit of physiotherapy. It'll settle, and you'll probably never get it again. It's just like spraining whatever other joints there are to sprain. So it's self-limiting. Degeneration is a cause of problem, and we'll talk a little bit more about that in a minute, and of course there are serious causes. So as I mentioned, in terms of sprain, you can sprain many different things. It's actually not really very important what you sprain. For you, it's probably very important what you sprain. For me, it's not so important what you sprain, because it doesn't matter what you sprain, because it all settles by itself most of the time. Okay, if it doesn't settle, then we worry. If it settles, then we don't have to worry. So those are the things, and we sometimes try to make a diagnosis, but as I mentioned, most of the time it will settle within a few weeks. There are the serious causes, and I just put them up here for your reference. Don't worry about it too much. Most people with back pain do not have these, okay? But there are a few that do. Fractures are usually fairly obvious, and because the spine is a very strong piece of bone, it's difficult to break most of the time. So fractures are usually related to high energy trauma, car accidents, jumping off buildings, and things like that. Although in people with osteoporosis, maybe a slight slip or even picking up a heavy bag can result in a fracture. So these are something that we as doctors, when you come to see us as doctors, we want to look out for. Infections like tuberculosis used to be very common in Hong Kong, now much rarer. And tumors, of course, and most of the time these are tumors that have spread from another organ. So whether it's breast, prostate, liver, whatever, they spread to the spine. Now, the hallmark of infections and tumor is they usually have pain at rest. So when you're lying in bed at night, completely still, and then the pain is there, then you have to worry. Okay, so I hope none of you have that now. But if you do, you should go and see a doctor. Okay, because we need to make sure that you don't have these. These are serious conditions that needs treatment quickly. But the majority of people have some degree of degeneration. We know degeneration is related to age, like having white hair and wrinkles. Everybody gets it as you get a little bit more mature. And there are certain factors, environmental factors like heavy load, exercise, injury, and so on. We'll talk a little bit more about that too. So this is a study that we did, a population-based study that we did in Hong Kong close to 10 years ago now, in which we just looked at the percentage of people with lumbar disc degeneration and the relationship with age. And what is perhaps staggering, at least to me, is that if you look at this, almost, well, actually, not almost, 50% of the population between 18 and 29 has some degree of this degeneration. Okay, and of course, this rises with age to 60, to 80, to 90 when you are 50 and above. So in fact, if you are 50 and above, although there are not many people here I noticed that are 50 and above, but if you are, to have a normal disc is actually unusual, right? So I think, therefore, the thinking, the mindset is, don't worry so much if you have a bit of this degeneration. That's normal. It's like white hair, right? You will get it. It's the other way around. So you have to learn, you have to accept the fact that you will have this degeneration. You may not be as good as before when you're younger, and you have to learn to live with it. I think that's a very important thing to bear in mind. Now, just to get this out of the way, if you have back pain, or indeed even neck pain, and you go and see a doctor, they'll take an X-ray, which often doesn't actually help a great deal, but they may see a few of these osteophytes here and there, and they tell you, oh, you got osteophytes, that's why you've got back pain. All right? Who has had this experience? Hands up. Yeah, a few. Okay. So osteophytes are basically a kind of radiological sign to just show that you have a little bit of degeneration. That's all it means. They don't stick into anything to cause pain. Okay, so don't worry that you have to cut it off. We don't have to cut it away. So they're just a little marker, if you like, to show that, okay, you have a bit of degeneration. But as I told you, degeneration is common as you age. Okay, so it doesn't actually mean anything to have osteophytes. So please don't worry. Please don't worry. Now, so what are manifestations of perhaps a more severe form of this degeneration that leads to symptoms? Well, usually it's either back pain or sciatica, or what we call spinal claudication. Now, back pain is perhaps obvious. You have a pain in your back. That may be related to motion only, or you may even have it at rest, as I mentioned. And sciatica is strictly speaking a pain in the distribution of the sciatic nerve, which means that the pain radiates down the outer aspect of your leg and goes below the knee into the foot somewhere. It can vary a little bit, but basically that's what it is. Now, so you have back pain if your back is degenerated, as we talked about earlier. You may have sciatica when the nerve coming out of the back at those degenerated levels are compressed. Okay? And that compression may be due to a prolapsed disc, or may be due to the fact that your spine is a little bit wobbly. Okay? Instability to an orthopedic surgeon is a very special word, which I don't want to use in a public lecture. Now, so prolapsed disc, what does that mean? Now, the disc, as I mentioned to you, is the joint of the spine. This is a little bit like a car tire. So it's got a very tough outer layer, and inside it is filled with a jelly. So this is a cross-section. So it's like you cut the body in half and you look from the top, and you can see the car tire on the outside, the rubber, and then the inside jelly. And then this is the spinal canal, inside which are the nerve roots and the back, and this is the spinous process, which you can feel sticking out the back. So when the jelly prolapses, when there's a crack in the outer layer of the car tire, the jelly can prolapse and it can compress the root. It can lead to pain, and that's what causes sciatica, leg pain. Okay, so that's disc herniation. It can also give rise to back pain because the disc itself, because it's now cracked, it's a little bit incompetent and it's painful. It can, because of the nerve compression, it can lead to some weakness when you walk. You know, big toe, or perhaps your leg may feel a little bit weak or wobbly. It may even fall over easily on rough ground. Some sensation loss, numbness, either over the foot or the outer aspect of your leg, most common. And in very rare cases, it can actually also lead to bladder and bowel problems. Okay, that's very rare. But if any of you, I'm sure none of you have that now, because you won't be sitting here if you have that now. But if any of you know of any friends or relatives in future, hopefully not, but in future who have bladder and bowel problems, they need to see a doctor immediately. This is one of the few rare orthopedic emergencies that we face if they actually develop bladder and bowel problems. Now, the other aspect of the disc, functionally, the disc is basically a joint. And this is a model that Professor Look, the previous head of our department, uses to explain this concept. So the disc, if you like, this area here is what I describe as a car tire inside which is a jelly. So it's like the balloon, a filled balloon. And when it's filled, the disc height is quite tall, the ligaments are all taut. And so not only does it allow some motion, but it also has a kind of, it's a shock absorber. So you can pump up and down. You can run, jump, and so on. It absorbs shock. Now, when the disc degenerates, the balloons flattens. The ligaments become lax. And you can imagine when that happens, it can become more wobbly. And it's this wobbliness that can result in some slippage of the body on each other, and then the nerves can be also compressed, as well as being painful. So that can be a problem, and if that is the case, then we might have to fix that too. Now, the other aspect is that of spinal claudication. What that we mean by spinal claudication is when there's a kind of general narrowing of the spinal canal, the nerves inside becomes compressed, and when that happens, they typically have the symptoms where they're perfectly well sitting or lying down, but when they walk a certain distance, they get this shooting leg pain. If they stop again, the pain goes away after a few minutes. Okay, so they often rest, and then they walk a certain distance, it comes back. So they have to start, stop, start, stop, start, stop, like that. That's very typical spinal claudication, very common. We see that a lot in our clinics. And that's usually due to some stenosis of the canal, not due to this, and that's usually due to osteophytes or other things that have degenerated and compressing on nerves, like this here, and you can see this on the MRI in what we call the lateral recess. Now, so that's kind of a very general introduction on this degeneration and pain. Then the question is, what actually causes it? Well, we know, as I told you, it's related to age. There are certain lifestyle or environmental factors that are involved, but is that it? Well, let me show you a real example of a patient of mine. So this is a 22-year-old young lady. And now that I've taught you how to look at MRIs, you can all spot what's the problem on the MRI now, right? Well, there's also an arrow there to help you too, if you cannot. So this is obviously a degenerative disc, and you can see that it's herniated. Explains her back problem. This is an MRI scan of her sister, who actually doesn't have back problem at all, okay? But she also has a mild degree of degeneration at the same level. Second one up. See that? Slightly darker, not so bad. And this is her mother. Same level again, plus the one above. So could there be something in this? Well, this has been an interest of ours over the past 15 years now, looking at genetic factors leading to this degeneration, and we feel that there are. Genes affecting the process from normal leading to degeneration. Now, at this moment, I'd just like to also acknowledge the Area of Excellence program and the theme-based research scheme that I'm involved in, and in particular, Professor Kathy Chair and Professor Danny Chan, who has been long-term collaborators of mine, and we have worked on this whole area, as I mentioned, for the past 15, maybe even longer. And indeed, I even use some of the slides that are produced by Professor Chair. I hope she doesn't mind. So here's another one. So what we have done over this time is that we have collected a cohort of population-based individuals, 3,500 Southern Chinese, basically Hong Kong people. And some of you, any of you volunteer for this here? There must be some of you. Yes. Well, you did. You didn't know this? My wife. Yes. She's in it. Yes. I took the blood while she was asleep. So with this cohort, we imaged their spine, we took their DNA, and we obviously did a lot of work with this. We've identified basically there are quite a few genetic factors that predisposes to this degeneration, and those are the ones that are highlighted in white. I'm not going to go into detail. If you are interested, our group has published on these, and you can read about them in more detail. So it's related to your genes, and it's likely that probably multiple genes are involved. And our more recent success in the theme-based research scheme is really to try to understand how the genes result in the disc being degenerated. So to try to arrive at a molecular understanding of this degeneration. And the reason why we want to do that is because it's only through this understanding will we be able to, one, perhaps develop personalized treatment, and two, novel strategies that would allow us to address these problems, rather than what we do now. And I'll tell you a little bit about what we do now later on too. So that's what we want to do in future, to identify genetic factors, improve diagnosis, individualized prognosis, and strategies for therapy. We're not quite there yet, but we're getting there, okay? Another 15 years, I'll tell you the results. So this is a little cartoon from the South China Morning Post. So there's certainly an inherited component, but perhaps there's more than just an inherited component to this. So what perhaps can be referred to as lifestyle factors. Now, there are many lifestyle factors, but there are certain ones that are potentially modifiable. Okay, if you like, some people call these environmental factors. Like the medical term is obesity, but perhaps overweight is a better one. Smoking, a sedentary lifestyle, and sleep disturbance. Now, the mechanism of why, for instance, overweight may lead to back pain is this. You have a big belly, that's obvious. If you have a big belly, you overload the spine. So that's relatively obvious. Yeah, don't look at your colleagues who are a little bit overweight in the audience. Try not to do that. I noticed a few of you were just turning around. Obesity is associated with atherosclerosis, narrowing of your arteries. So if your arteries narrow, that can actually reduce the blood supply to the disc, and that may cause degeneration. And also, it is known that fat cells secrete these chemical mediators that can actually cause inflammation and these problems too. So that's overweight. Smoking, pretty well known. If you smoke, your arteries are reduced. Again, you reduce the blood supply to the disc. And perhaps, by the way, if you smoke, you may or may not know this, smoking is an indicator that you have an underlying psychological problem. Okay? Okay? So if you smoke, you should go and see a psychiatrist. Right? And of course, also vascular inflammation, atherosclerosis too. Now, a sedentary lifestyle, of course, could also result in obesity. And if you don't sleep well because you have a psychological problem, then these all add up in terms of anxiety, leading to chronic stress, and then your inflammatory mediators and so on. So all these kind of tie in. The big question, of course, is if you reverse all this, can you get better? Right? Isn't that interesting? So I thought we might just take a quick poll. Who thinks if you lose weight, stop smoking, do some exercise, and sleep well, you can get rid of all this problem? Hands up. Who thinks you cannot? Well, there are a few more people who think you can than you cannot. Well, the bottom line is that there is actually no high-quality evidence that you can do it. So for those of you who want to keep this lifestyle, take a quick picture of this slide now and show your partner. Okay, I see all these people putting up their cameras. Now, having said that, okay, are you done? Having said that, I'd like to share with you a little story too that was published in the British Medical Journal in 2003. This was a study in search of high-quality evidence that if you jump out of an aeroplane without a parachute, will you die? Okay? This is what the study is about. Because most people would only jump out of airplanes with parachutes. Okay? Nobody has ever jumped out of an airplane without a parachute, right? So they did a very extensive search of the literature, found that there was, in fact, no studies. There's no high-quality studies, randomized controlled trials. None have ever been done on this topic. And so, therefore, they suggest that for the radical protagonists of evidence-based medicine, always looking for these high-quality clinical trials, they should participate in a double-blind, randomized, placebo-controlled crossover trial of the parachute. Okay? Or, to put very bluntly, individuals who insist that all interventions need to be validated by randomized controlled trial need to come down to earth with a bump. Okay? So sometimes it may not be possible to generate high-quality evidence, and perhaps if these things are sensible, you should do it, right? And it's not difficult to lose weight, stop smoking, do a bit of exercise, and try to sleep well. And probably if you do all those, you will sleep better anyway. At least your partner probably won't be nagging at you anymore, so you should sleep better. So just summarizing, in terms of lumbar disc degeneration, we know that, as I mentioned, it's related to age, it's related to genetics, systemic factors that we kind of talked about, nutritional, blood supply, injury, biomechanics, and all these probably act via some biochemical pathways leading to degeneration. And the degeneration in some individuals will lead to pain. And we, as surgeons, treat this pain at this level now. What we are hoping to do with the basic science program that I've explained to you a little bit about is to see if we can, by understanding this, by discovering these pathways, we can intervene at a much higher and perhaps more sensible level. And as I mentioned, this is ongoing work, and hopefully we can tell you more about this and perhaps even radically change the way that we manage back problems in future. So Before that, you need to know a little bit about how we treat back pain now. So I'm just going to tell you a little bit about how we treat by conservative and surgical treatment, and perhaps, hopefully, dispel some myths and help you understand a little bit more about the rationale for treatment and so on. Now, conservative treatment. So basically what that means is we don't operate on you. Okay, that's basically what we mean. Painkillers, often helpful, but of course temporary relief. Physiotherapy, very helpful, and I know that we have a few physiotherapists here in the audience. That's why I have to say that it's very helpful. And then the other one, common. I think probably many of you who's heard that if you have back pain, you should sleep on a hard mattress, right? Or sleep on a board, sleep on the floor, or put a board underneath your mattress, right? All these are various things, okay. So I probably should poll my department to see how many people actually give this advice. Who thinks this actually works? Hands up. Oh, okay. Well, there are, I don't know, about 20, 30% people. There is high quality evidence in this matter, okay? So this was published in The Lancet in 2003. And for members of my department, there's hope for us yet. You can see that you can do a randomized controlled trial on the firmness of a mattress, and you can get this paper in The Lancet. Huh? Right. So, and basically what this paper shows is that there is no evidence that a hard mattress is actually better. So the advice is probably you should go on a medium hard mattress, not a really hard mattress. Okay, certainly don't sleep on the floor or on the piece of wood. It's far too hard, not very comfortable. Now, physiotherapy. So if you have back pain, your doctor refers you to physiotherapy, you probably have one of these treatment modalities. Do they work? Well, you're getting this. You're getting this. There probably is not a lot of evidence that they do. No high quality evidence. Thank you very much. There's no high quality evidence that they do any good, but they may do. And I can tell you I've had some physiotherapy too in the past. Not for my back, but for my other problems. I'm not convinced that it really works, but it feels good anyway. Right? So, I mean, you can try some of this, but just be aware of the help that you may gain from this. But perhaps more importantly is you need to look for, and sorry, by the way, I mean, most of these, even if they work, it's like taking a painkiller. It's a time of temporary relief. For those of you who've had back pain and have had physio, you know this, right? You go for a treatment, you get better for a couple of days, and then it comes back. And then you just have to basically wait for it to settle. So it's fine, you can have it, but perhaps it's not that different from a painkiller or painkiller injection or whatever. So you really should try to look for something longer term, okay? And the two most important things that I tell my patients are, 1, posture, and 2, exercise. Posture. So this is just describing the load, how much, some people did some experiments to measure how much load your disc experiences in different postures. So when you stand up, if you standardize this as 100%, if you lie down, the load on your back is reduced by 25%. Right, that's sensible. Okay, so you can use this to justify why you have to sleep during work. All right. Now, you sit down 150%, and I think for people who suffer from back pain, you realize this, right? You can't sit for a long time. You sit sometime, you have to get up and you have to walk around a bit. That's why. Okay? If you bend over, 200%. So don't pick up anything heavy, and I think most people know this too. If you have back problem, that's why you can't pick up that $1,000 bill, right? You bend over, it's 200%. Okay? So you get worse. And then, if you sit and bend over, it's even worse. Okay? So don't bend over, don't go and tie your shoelaces or take your shoes off or whatever. So beware of your posture. And this, of course, is no good, right? So this is the ideal. Okay, you stand straight, tuck your tummy in, shoulders, pull them back a little bit. How many people stand like this all the time? How many people do you think can stand like this? Not many, huh? Why not? Why can't you just stand like this all the time? Well, it's tiring, isn't it? I mean, let's face it. is tiring. And this is why it's so important to do exercises, okay? Because basically to stand with a good posture for your back, you need a lot of muscle activity to maintain this posture. And many of you may have heard of now the so-called core muscles, C-O-R-E, the core muscles, okay? These are your abdominals, your back muscles. These are the muscles that if they act, will keep your spine straight, okay? So you need to exercise these muscles. And the concept to me is if you have a bad back, okay, it's rather like a flagpole, your spine is on the flagpole, it's waving about in the breeze, it's not stable. So what do? You tie some ropes around it so that it doesn't wave about so much. So the muscles that you strengthen act like these ropes and stop your spine from waving about in the air. Okay? Now, to strengthen these muscles, there are various ways, and one of which is, again, commonly talked about is swimming. Okay? Why is swimming good for you? Because it strengthens your back muscles. Not many people enjoy swimming in Hong Kong in the winter, or just don't enjoy swimming at all, right? So you can do other activities. In fact, most sporting activities will to some extent strengthen your core muscles. So my kind of advice is, because it's so important for people to do exercises, I think it's more important for you to choose an exercise that you enjoy and that you will do every week, as opposed to tell you to go swimming, and then you only swim twice a year. Right? That's not going to help. Or you just go swimming when you have pain. You don't go swimming when you don't have pain. That's very common. That doesn't really help. Doesn't prevent anything. So the practical aspect is find an exercise that you enjoy and try to keep doing it. Because at the end of the day, if you think about this, it's your endurance muscles that you need to strengthen. Okay? Because you're standing around all day, and that you have to keep them straight like this. So it's endurance. This has to be long-term, repeated exercise. And that's why, by the way, I took up marathon running. Okay, because that's endurance. Another quiz. Okay, we might have to quiz the male and female separately on this. Okay, but what do you think? Is this good or bad? Who thinks this is good? Yeah, all the men are putting their hands up, right? Right. Who thinks this is bad for you? Oh, very good. Okay. All right. There are two, by the way. I don't know if two persons put their hand up who thinks that high heels are good, which is fine. But in fact, it probably is bad for you. And most recently, I was just doing a little bit of a search. And there is data on the Chinese looking at the position of your spine when you wear high heel shoes. Okay? Well, when not you necessarily, but some people wear high heel shoes. And basically they found that with high heel shoes that you tend to lean forward, and as a result you have to arch your back. And so it's actually at least the posture changes. Now whether that change in posture is associated with back pain, there is no high quality evidence. Thank you very much. Yes. So it's not all bad. All right. Now, surgery for back pain. There are many, many, many different surgeries for back pain, and I have some colleagues here in the audience I can see who I'm sure will do. For spine surgeons, for orthopedic surgeons, we all like to do different things. So if you go and visit 5 spine surgeons, they probably tell you there are 5 different spine surgery for the same problem. Okay, so it's very, very confusing. But so let's just talk about principles. If you have a disc herniation, you need to have that removed, decompressed. And if you have some instability, you might need to have it stabilized. Okay? So this is what we mean by decompression. So if you have this little disc herniated, compressing on that root, you need to remove it, okay, and to decompress it. So that's kind of one operation. And if your spinal segment is wobbly, it's not stable, then you might need it fused. So here is some screws sticking and keeping this together. One issue that has been described in the past is when we do this kind of operation, a fusion procedure, it throws stress on the level next to it. We call this adjacent level degeneration. And that's why, in fact, disc replacements have been developed. So rather than fusing that level, we replace it with something that it moves. That's fine. Now, we don't do this kind of operation because the rationale to me for doing this would be that you preserve the adjacent level because of the motion-sparing nature of this procedure. But again, I can tell you now with 15-year experience around the world, perhaps even longer, 20 years, this replacement does not prevent adjacent level problems. And that's why we don't do it, actually. Because if it doesn't, what's the point in doing something like this? It doesn't last forever. It's like replacing a car tire. It doesn't last forever. Right? You have to replace it again and again, possibly. So remember this. So why do you think that it doesn't prevent adjacent level problems? Anybody hazard a guess? We have a very intelligent audience here. Because the cause of this degeneration is not. Thank you. Who said that? Okay. Yes, well, there is definitely a genetic component to this degeneration, as I mentioned earlier. And if that component is more important than the biomechanical component, then this is not going to stop the disc from degenerating, right? So keep that in mind. Now, moving on to another slightly different subject matter that's very close to my heart too, scoliosis. So this is a problem that can lead to back pain, certainly, if left untreated, and it affects people of different ages, as you can see here. That's what it looks like on an X-ray. Scoliosis is basically a curvature of the spine. Normally the spine in this X-ray, when we're looking from the front, should be straight, and here you see that it's bent. Now, there are many, like back pain, there are many different causes for scoliosis. You can be born with it, you can have other syndromes, neuromuscular problems, but the most common form is what we call idiopathic, and that's what, in fact, for doctors, that's just a fancy term for telling you that we actually don't know what the cause is. Okay, it's idiopathic, okay? But we use it a lot. It sounds good, okay? Now, scoliosis has many different consequences. Of course, if you have something like that, it doesn't look very nice. And because adolescent idiopathic scoliosis is the most common form, and it tends to affect girls, they don't look very nice. Okay, but that's, to us, perhaps as doctors, is not the most important reason. Is the fact that they can impair lung function. And you can see that if you have a curvature in your spine, in your thoracic spine, and this spine is actually next to your lung. So it actually can kind of occupy lung volume, stops the lung from moving properly, and it can result in early death as a result of severe scoliosis. Of course, you can get back pain too, because of the asymmetric loading of the spine. Now, adolescent idiopathic scoliosis, as I mentioned, is the most common form, and much more common in female, adolescent age in onset, related to the growth of the spine. So when they grow, they tend to deteriorate, and they can look something like this. This is already pretty severe, but more commonly, they look something like that, which is not very obvious, right, in the early stage. Although if you look more carefully, perhaps there's a little bit of asymmetry of the waistline, the shoulders slightly asymmetrical at the top, and so on. So very subtle. And that's why, in fact, some 15 years ago now, our department, under the guidance of Professor Look at that time, started a school screening program with the Department of Health. And for the younger people in the audience, who has participated in the school screening program? You should have done. If not, you can come up now, I'll screen you. You have. You want to come up too? Sorry. You have scoliosis. Okay, all right, okay. Well, I'll give you my name card later. Okay. So this is the screening program. I won't go into this in detail. This is a slightly older technique, which is actually difficult to do nowadays. So we are actively looking into using newer technology, and this is non-invasive ultrasound as a kind of zero radiation method of detecting scoliosis. We've just installed one of these machines at Duchess of Kent Children's Hospital and also at our Hong Kong Youth Surgeon Hospital as well to screen for these individuals. So, and I can tell you, based on a review of our work over the past 15 years or so, we have one of the best, if not the best, screening program in the world in Hong Kong. So you should be very proud of this. In terms of our ability to pick up scoliosis, not so many, reduced false negative, etc., etc. So that's the screening. Now, the reason for early detection, the reason why we want to find these people early is because if we get them early enough, the curve is mild, and we put them in a brace like this, we can actually stop them from having surgery, stop the curve from getting worse, and therefore they don't need surgery. And there is high-quality evidence, okay, that bracing actually works. And this is a recent publication in the New England Journal of Medicine 2013, or 13, if I remember correctly. Right, to show that they actually work. Unfortunately, some people slip past us, other people will deteriorate inside the brace, and they may end up having surgery. So this is that young lady before surgery, and the same lady after surgery. So we can do pretty good. They look better, right, after surgery. So we can do that. And that's what the X-ray looks like. So before surgery, after surgery, and that's just from the front and from the side. The only problem with surgery is we put in these screws and rods and so on, we pull the spine straight and we keep it straight. So it's a kind of a scaffold inside the spine, and the segment that we've operated on while straight, it doesn't move anymore. Okay? So it's not the best thing for the spine. I mean, you want to be mobile, you want to be able to twist and turn and so on. Not that they can't move, they just have a reduced range of motion, okay? This is a very successful operation. So please, I'm not saying that this is bad. This is very successful, as I showed you. Even the postoperative results in terms of blood loss, ability to get up after surgery, going home, back to school, back to work, it's actually not bad. So yes, I mean, spine surgery is major, but as spine surgery goes, I think this is a successful procedure. So if you ever have any friends, patients, our affected individual here, don't worry if you ever need to have surgery. It's very good. Although, having said that, we were not satisfied with the results of the surgery, and we have been trying to develop better ways of treating these individuals, getting more correction in a safer manner. And again, this is work that we have been doing for the past 10, 12 years now, in collaboration with the City University of Hong Kong, to try to look for new ways of treating this. And I'll just show you this very quickly. So basically, we have developed a super elastic shape memory alloy rod. This is really high-tech stuff, in which the rod will continue to exert a force on the spine after we've implanted it to gradually push the spine straight. So this is just a little animation to show you the concept. Okay, this is quite an old animation, so this is not exactly how we do things nowadays. But you can see we put it in, close the wound, and gradually it pushes the spine straight. So this has gone through a series of lab studies, animal studies, various modification of the surface to enhance its properties, and finally, a randomized controlled human clinical trial to demonstrate that it is, at least in the first stage, safe and equivalent to other techniques. So this is what we've demonstrated. And since then, we have actually spun off a company. And the aim would be we'll be, over the next 1 to 2 years, manufacturing rods and starting a large-scale multi-center clinical trial to demonstrate its effectiveness. And hopefully, if we are able to do so, again, we will be radically changing the way that we treat scoliosis. Radically because for many people around the world now, they are using stronger and stronger implants, stiffer and stiffer rods to try to correct them, pulling harder and harder, whereas we're doing it very gently. So it's a kind of different concept. Now, just moving rapidly onto another area in younger children now. So early onset scoliosis, these are children with scoliosis under the age of 10. Very rare, but they can be quite nasty, as in this young lady here. They are a different problem altogether because these are in children, so the spine is growing, their lung is growing, and if we don't keep them growing, they end up short, they end up with impaired lung function, etc., etc. So bracing doesn't work because in young kids, their bones are too soft. You press on it, they just deform. They don't actually correct. If we do a fusion that I showed you earlier, they will just end up shorter and shorter because whatever we fuse together, whatever we put screws in and stop it and keep it straight, that segment won't grow. So therefore, the concept of a so-called an internal brace or a growing rod was developed. And this is an example of a young boy, or girl perhaps, with a deformity in which you implant these kind of rods. The rods are actually separated in the middle so that every 6 months we put the child under general anesthesia, we reopen the wound, and you can push the two rods apart. And by doing so, this lengthens, and it kind of grows with the child, and it's an internal brace. It's a great thing, it stops them from getting worse, but it's terrible psychological trauma as well as surgical trauma for the child. Imagine every 6 months, a 5-year-old child has to come back for surgery, and they may have 10 or 12 surgeries before they actually finish growing. And not only that, with the surgery, there are complications. The more surgery you do, the more likely you're going to have complications related to that. Breakage, wound infections, etc., etc. So about 6 years ago now, we have worked with a company in the US to develop a magnetically controlled growing rod, basically a remotely distractible growing rod system, whereby we can lengthen the rod without actually putting the child to bed. And so we actually performed the first of this kind of surgery in Hong Kong 6 years ago, 6.5 years ago or so now. And this is one example of a child with a big curve. You can, by using two relatively small holes, I hope you consider this small. To us, this is very small holes, by the way. Okay, you may think it is large, but it's very small. Okay, and we put in the screws, thread in the rods, and with the internal brace looking like that. So this thickened portion has a little magnetic motor inside, and so I'm going to show you how we distract this. So this is actually, oops, excuse me, let's move that out of the way. This is actually, I'm going to show you a video of the girl who is the first girl in the world to have this rod implanted in her. Okay, 5-year-old at the time she had surgery. She's probably a little bit older in this video. So the rod is already implanted. So I use this little device. She comes to our clinic. You can see she's awake. She can move. You will see her move in a moment. Okay, and then, yeah, there you go. See that? And then we put this on top. And you press the button. 30 seconds, it makes a noise. Goes whoosh, whoosh, whoosh. And then the rod distracts. 2 millimeters. Okay, about 30 seconds. So she comes back every month, and we distract her a little bit at a time. And I can tell you the most amazing thing about doing this procedure is when the child now comes to see us in clinic, she actually smiles. You know, in the past, these people, they don't want to come to the clinic. Okay? They don't want to see us. You know, we are horrible people. So we published our results in The Lancet in 2012. And to show that in this first-in-man clinical trial that the rod was safe, good patient satisfaction, maintained spinal growth, and importantly, shorter hospital stay, less psychological burden and pain for the patients. So this, I think, is a very nice procedure to do, a little bit expensive. Still trying to get HA to pay for it. Hopefully they will. And Professor Paul Tam, in fact, in the audience, gave us the Research Output Prize in 2013 for our work on this. We also attracted other interests too, with the help of Dr. Kenny Guan, who's also in the audience here, who seems to know many Miss Hong Kongs. So YIN Association supported us and to further develop an early onset scoliosis program. So here you can see many Miss Hong Kongs, and these are the children who have actually had these rods implanted in the past. And we had a little celebration at the Duchess of Kent Children's Hospital. So that's in the very young. And now in the adult. You can also have scoliosis in the adult too. And that can be a result of because it hasn't been treated in the past, or it may be because it's something that occurs so-called from new. Okay, and that's because of perhaps osteoporosis and degeneration. So you can also get scoliosis developing too. And in these, they have a lot of pain. Now, in general, these are usually severe and very difficult to manage without surgery. Eventually, they probably will end up with some form of surgery. And I don't want to, for those of you who does have this problem, I don't want you to feel particularly gloomy in terms of your outlook, but it's treatable. So this is somebody with 109, and you can see it's a big curve anyway, something very big. Now, we can operate on these individuals, and we may even enjoy operating on these individuals because they are challenging, and as surgeons, we enjoy doing challenging things, right? But having said that, these are big operations. These are big operations, and they are lost. It takes a long time. There's blood loss. You can see these very long fusions, and the complication rate is high. Okay, so these are not something that we would want to do, although we can do it. Not necessarily we want to do it. So I think the bottom line and the message I want to send out is it's better to treat this early to avoid these very big problems. And I think that's something to keep in mind. And in fact, very often we talk to adolescents, suggesting that if they have a fairly severe curvature, we should treat them at that stage before they get to these really big problems. So, summing up, I think spine surgery has advanced a great deal over the past 20, 30 years. It's advanced in terms of understanding of the different problems that we see in people with scoliosis, and the ways that we treat them now is different and I think nicer for many of our patients. From our understanding of low back pain, I think we have changed people's understanding. It's not a matter of wear and tear anymore. There are biological issues involved, and perhaps in future we can be thinking about personalized treatment, new strategies. I hope I have dispelled a few of your myths in relation to back problems, but perhaps a very important message that I'd like to give all of you is that whatever you have is actually treatable. So I will be leaving my name cards out at the back. So you just need to go and see a doctor, right? So finally, I'd just like to thank Mr. George Ho, the late Mr. George Ho, for really supporting our research in these different areas. There's, of course, members of my family who has been really solidly behind me all these years, as well as past people who worked in my lab, the area of excellence and the theme-based research scheme, or the people that are involved in those, as well as our international collaborators here gathered at a spine and pain symposium that we organized a couple of years back. So it really has been very much a collaborative, international collaborative, multidisciplinary effort that has really got us to where we are today. Oh, as well, of course, all the funding agencies that have supported all these different works in the past. So, finally, I'd just like to show you one final trick. And if you see a $1,000 bill, sorry, I should say no, you should not pick up money from the ground, right? You could be arrested for doing that. Okay, so if you have dropped $1,000 on the ground, you can still pick it up even if you have back pain. All you have to do is to kneel and not bend. So while I wish to give this to one of you, I hope that you have felt my lecture today has enriched you in other ways. And I thank you all for coming. Thank you very much.
Thank you, Professor Cheung. And I'm sure we all learned a lot about our spine and how to protect our body. And for those of you who have back pain and didn't pick up the $1,000, I would like to open the floor for questions, chance for a free consultation with Professor Cheung. Yep, Professor Matheson.
And when the phenotype of the condition is so common and so influenced by age, How do you begin to do a genetic study?
I can tell you are the president of the university because you ask these really difficult questions, right? And that indeed that has been something that we have struggled and argued and discussed over the years. I mean, so there are several aspects. One, we have to perform some sort of age adjustment. And that's where our population study in the past becomes important. So we do have a sense of the population prevalence of this degeneration in relation to age. So that's one aspect. And the other aspect is identifying what particular phenotype that we're getting at. And we have some very clever people. Professor Pak Sham is here, and he has many students that are really very clever at trying to dissect phenotypes and making sense of this from a genetic perspective. I mean, it's rather involved to kind of explain to you very briefly, but it certainly is not just a matter of seeing a disc herniation or a disc that is black. Yes.
You don't mention chiropractor or acupuncture. I should be like that.
What do you want me to say? No, I think, no, joking aside, so the question was, I didn't mention chiropractor or acupuncture. I can tell you that I have actually done a study on acupuncture in the past. I think acupuncture actually works, okay? It's probably good at stopping pain. I'm not sure that you can really do much more than that. But I don't know whether any people in Chinese medicine here who will be flying needles at me, throwing needles at me. But it can certainly help with pain. I'm quite convinced of that. So you can certainly try acupuncture if you have bad pain, and you may be able to, after receiving it, get up and walk. Chiropractor, I think as a method of treatment, possibly okay. There's not a lot of science in what they do. And the thing that really gets us a little bit is when they start drawing little dots on the x-rays and tell you that you're a little bit rotated and they have to come up, push and rotate you back. That's kind of very much pseudoscience to me. So that's one aspect. The other thing that I have seen, and I think you should all be a little bit careful about, is sometimes they are so vigorous in their manipulation that they paralyze people. And we have treated a couple of patients who has developed hematoma in the spinal cord as a result of very vigorous manipulation. Okay, so just be a little bit careful. But otherwise, I think, yes, if they do traction, manipulation, massage, those are probably okay.
In the back, gentlemen. Okay,
I notice you've been standing up all the time at the back, so
sitting all day is making up for it.
we understand.
Hi. I'm a lay person in terms of medical knowledge, and this is really helpful for me. Thank you so much for your lecture today. I had two questions, if I may take the liberty to ask. The first one with regards to yoga. I'm from India. We see a lot of practitioners of yoga, and it's suggested for especially anything to do with the spine or physical deformity. So if there have been any studies or your view on it. The second would be with regards to marathon runners. You talk marathon runners?
Marathon runners.
Yes,
okay.
In terms of, there is this good part of it which helps your circulation, etc. But in the longer run, they say it has too much stress on your knees as well as deterioration. So moderate amount of running is better than endurance running. So your views on both of these, please.
Okay,
Thank you.
very good. Marathon running is a subject that's very close to my heart too. I can give you another 1 hour talk on that. Now, so first on yoga. It's good. I think yoga is a good method because although I don't do it myself, my understanding is that it does strengthen core muscles, and it also helps with relaxation, which stress and all that is all often part of back problems too. So I think yoga is good. The only thing is you have to be a little bit careful in terms of how much stretching or bending you do. Don't overdo it. If you can't get to a certain posture, don't get somebody to push you, into it or something. That's probably not good. One, and the other aspect is that pain is a warning sign from your body. So if you do it and the pain is worse, it's telling you that you shouldn't be doing it. Okay, so you just have to be a little bit careful, but I think yoga is a very good form of exercise. Marathon running on the knees. There's not much evidence on the back. I actually did try to look this up. But marathon running on the knees, does it cause degeneration of the knees? No. I have actually done a literature review on this with regards to my own interests and my own needs, I can tell you. So that there is no evidence that it can cause degeneration for several reasons. One is that marathon runners tend to be thinner. So the issue of weight has gone away, one. And then two, there are some studies to suggest that when you move your knees, okay, when you're pounding up and down, the nutrition actually improves the cartilage. So it's not a static state. Sometimes it's actually the dynamic state that actually improves the fluid flow and nutrition. So it actually may not be all that bad for the cartilage. And certainly there is no evidence to suggest, no high quality evidence to suggest that in marathon runners they have more osteoarthritis of the knees.
Gentleman in the middle row on the left. Yeah.
Thank you, Professor. Most Chinese elderly like to play Tai Chi Chuan as morning exercise. Do you suggest they continue the exercise for the low back pain patient? Is it benefit or may get more injury?
I think Tai Chi is good. And there has also been some studies done to show that Tai Chi is very good for the elderly in terms of the muscle, their position sense and endurance and preventing falls and so on. So Tai Chi is good. I don't know about specific studies looking at back problems, but my advice would be exactly the same. If you are doing a certain posture or motion that seems to bring on the pain, you probably should not do that particular one. But otherwise, yes, please keep doing it. It's a good form of exercise.
Here in the front on the right.
Yeah. I'd like to ask, when is it when pain is just a discomfort, and when is it a moment that we should be, seeing specialists and getting MRIs and X-rays and things like that?
That's another very difficult question to answer. Okay, I think two things. At one level, to me, again, whenever I talk to patients, I think pain is very personal. So if the pain is affecting your daily function in whatever way, you can't sleep, you can't go to buy food at the supermarket, you can't do your exercises or whatever, if you would like the pain to go away because it's affecting your function, then you will probably go and see a doctor, right? So if it's minor, it doesn't seem to affect you, but it's just, every now and then you get a little bit, probably, you don't have to. So that's one aspect. But having said that, remember that there are some serious causes of back pain. And so you need to exclude those first. So if you are concerned in any way, if the pain is persistent, let's say for more than a few weeks or a month, then perhaps if you're not sure, that it's just easy to go and see a doctor, get it checked out first, make sure you don't have one of those serious conditions before you start ignoring it.
Lady in the middle, in the back.
Hi, Professor. I am an MBBS Year 3 student. I really enjoyed the lecture. Wish I had your lecture in the MSS block. And my question is regarding the...
Our dean is not here, actually. I know.
Okay. Okay, so my question is regarding the super elastic NITI rod that you mentioned just then.
Right.
So my understanding is that it provides a gradual correction of the curvature of the spine. So I'm just wondering, does it still impose a motion restriction, though, because of its rigidity?
Very good question. It does impose some motion restriction because, yes, the rod is more bendy, actually, because it's super elastic. It's more bendy. But that will also all metal inside your body, if you keep bending it, will eventually fatigue and break. So we do perform what we call a spinal fusion, which takes about 3 months. So after 3 months, the spine will become solid, and the segment that we've operated on cannot move again. Right? So yes, so there will be some motion restriction. It's still not the best. The best is if we can find out the cause of scoliosis, which of course we're also doing, although I haven't told you much about that part of our work too. And to, again, stop it before it gets worse.
I think I saw a hand pop up somewhere here. Yes, on the right side.
Professor, thank you very much for a very enlightening lecture.
Thank you.
To me, I'm sure it's worth far more than $1,000.
Okay. Well, I'm happy to open my pockets too.
Now, I have something to offer in return, and then a follow-up question.
Okay.
Firstly, on the core muscles. From my own experience, I find that there are two exercises that can dramatically improve the core muscles. Swimming, of course, is one form of exercise, but there is a target-specific style of swimming that can improve the core.
Okay.
Not the freestyle, not the breaststroke, but it's hard to do, but then there is a modification. You can swim your arms in breaststroke, but use the butterfly legs.
Wow.
Then, because the butterfly stroke actually exercises your abdominal muscles and the back muscles alternately.
Right. Okay. Very good tip. Very good tip.
If you don't want to swim, there is an alternative.
Yes.
Learn samba dancing in Latin dance. It has the same motion.
Okay. That's much more interesting.
Of the spine.
That's much more interesting.
So,
samba. Okay.
After offering these in return, I have one question to ask. Recently, I tried to exercise the core more aggressively, but of course, it takes shorter time. And I don't know if it's good or not. Okay, it's using the exercise roller, a wheel in the center with two handles.
Ah, yes.
And then you can, of course, if you want to do it easy, go on your knees. All right, but if you want to exercise the lower ab muscles, then doing it in a standing posture, stretching it out far, almost parallel to the floor, and then come back. It's very strenuous, but I do not know if it will really hurt, because I'm just attempting, doing it bit by bit.
Right.
So this is my question.
I don't have an answer for you. Most of my experience of strengthening muscles is my personal experience, let me tell you, which is not good because I'm quite lazy. But I think, well, in fact, Margaret is here. She is helping us with doing some programs looking at rehabilitation and you know, all these exercises. And many of these exercises and how we train our muscles is actually not scientifically tested, and something that Margaret can think about. So I'll task her with this. She can give the next lecture, okay, in a year's time.
Okay, so I think in the interest of time, those who still want a consultation really have to pick up your name card. But I believe that we will all go home and start swimming and start exercising and hopefully never jump out of a plane without a parachute. And so I would like to ask the audience to join me in giving a warm thanks to Professor Cheung for a very thought-provoking lecture. And thank you all for coming.
Thank you.